All right, everybody, it is Dr. Eric Balcavage and my partner in crime, Dr. Erica Riggleman, live from Winchester, Virginia, right?
Yes.
So we are talking today on our Thyroid Answers podcast number 12. We're talking today about hypothyroidism and GI problems. Really, really common for people with hypothyroidism to have GI problems, especially constipation. And what we thought we'd do today is give you some reasons why you may struggle with GI problems, whether it's reflux, constipation, diarrhea, gas, bloating, pressure. We just thought we'd go through a whole bunch of reasons why it is totally normal to have those things. And we thought we'd go through some of those things, explain a little bit about those, and then talk about some things to consider doing to help you with your challenges, right?
Absolutely. And so when we're talking about the gut, what would you say the biggest complaint that a patient comes in that is relating to gut problems? Would you say that constipation is the number one thing most patients are complaining about that you see, or is it the reflux, or what's the big thing you're seeing in your office?
Well, I think constipation for the hypothyroid patients is really, really common, and it's not unusual, and there's many reasons for it, but definitely thyroid hormone directly affects motility of the bowel. So there is the bowel, food moves through the bowel in this with this thing called a migrating motor complex that kind of moves the chyme, the digested food, through the process. And thyroid hormone plays a key role in motility. And it's not just thyroid hormone, but what we see in patients who have Hashimoto's, actual damage and attack to the thyroid gland, is the loss of something called thyroid motilin. And if people aren't aware, motilin is an enzyme that's secreted in the GI tract by things called enterochromatin cells. They're part of the cells of the GI tract. And the enterochromatin cells were thought to be the only release of this motilin. But what's recently been found is that people who had thyroidectomies had increased constipation. And when they supported them with thyroid hormone, that helped. But motilin is actually made in the thyroid gland. So if there's thyroidectomy and you lose the thyroid gland, you lose your thyroid motilin. If you have Hashimoto's, you lose you get enough cellular damage there that you lose the production of thyroid motilin. So without thyroid motilin, the bowel may not move well. So the direct effect of the thyroid hormones on the GI tract can cause a problem with motility, and loss of thyroid motilin from the gland can also impact motility directly. So those are two primary causes that the thyroid can have. But there's also problems with reflux, right?
Oh, absolutely.
So there's a tie-in. People who have hypothyroidism have decreased esophageal and gastric motility, so we have decreased or slower movement. They have a higher prevalence of having hiatal hernias. So the part of the stomach actually sticks up above the diaphragm, and that piece gets kind of stuck there, so food doesn't move real well. And thyroid hormone plays a direct role in gastrin production and stomach acid production, as well as bile acids and pancreatic enzyme secretion. So it hits every aspect.
Yeah, and not to mention that thyroid hormone also plays a major role in the brain's function and the neurological function. So if that is also affecting the way that the vagus nerve is stimulating, not only to make hydrochloric acid or to stimulate motility through the vagus nerve, you're also going to have that brain-gut connection where you're just losing the connection from the brain telling the gut what to do, which is going to make you constipated, slow it down. You're not going to digest your food. You may start to see undigested food in the stool because you're not even able to digest it very well.
Yeah, I think the problem is shouldn't be eaten during the podcast. The problem is multifaceted when somebody's got GI problems. And so definitely if we start from the top, somebody's got hypothyroidism, they're going to have decreased motility right off the bat, right? So esophageal motility, so they can feel like the food gets stuck, like it can't move real well, so that can be a major issue. If they have hypothyroidism, and when we talk about hypothyroidism and its impact on stomach acid secretion and motility, this goes back to one of the things we talk about quite a bit, and that is it's not T4 that does this stuff, it's T3. So to have good GI motility and to have good acid production and to have good bile acid secretions, we have to have good transport of T4 and T3 into the cells. So we go back to our cellular hypothyroidism. You can still have good normal levels of serum T4, but if we're not getting that T4 converted into T3 into the cells, then we're not going to have appropriate stomach acid production, appropriate motility. And the stomach acid then is really key. If you don't have appropriate stomach acid production, then you get gas, pressure, bloating pretty quickly after a meal. And that can lead to esophageal damage. And the acid production is key to the proper secretion of the rest of the digestive enzymes, bile and pancreatic enzymes specifically.
Yeah, that's a huge thing that I see in my office is that usually when they've got motility issues, they've got constipation, they also either have had their gallbladder completely removed because they thought it was a gallbladder problem, or they've got an extremely sluggish gallbladder to begin with, then they're not absorbing fats properly, their vitamin D is going to be low, and it just, the whole cascade just, I mean, the gut health is so important at such a foundational level at all aspects.
Mm-hmm. And I think we see, when we see people who have slowed motility, these are people, especially hypothyroid patients, that are going to be a much higher risk of Sibo. And Sibo is small intestinal bowel overgrowth. And what happens is the small bowel is designed to have a very small concentration of bacteria in it. The colon and the large intestine are designed to have lots of bacteria in it, and that's pretty normal. But when there is slowed motility, then bacteria has a longer period of time to act on the food, and that can create increased gas, increased production, increased bacterial growth, and that can create a lot of the symptoms that people get, the gas, the bloating. That's like an hour or so after a meal, they start to get this irritability, this indigestion, and they can get a lot of buildup of toxins that start to affect them. And as the bacteria starts to overgrow, and they get their symptoms, one of the things that happens then is they get a doctor may say, well, you have IBS, or you have, even if they have Sibo, they may get treated with an antibiotic, and that can temporarily possibly knock down some of the bacterial load, but it doesn't really address the underlying problem.
Yeah, and even if they take the antibiotic, once they stop it, they still don't have the mechanisms in place to protect the digestive system from re-exposure. And then if they don't have enough stomach acid, I mean, that's the first line of sanitation in the body. You know, the food that we eat isn't 100% pure. There's always going to be some sort of, bacterial exposure on there. You can't rinse off everything, and you can't see it with the naked eye. And so if you're getting that to the bowel, it's constantly going to reinfect because your body wasn't able to sanitize it in the first place.
Right. And I think that's one of the biggest things we see in cases of small intestinal bowel overgrowth is, and it's really common in people with hypothyroidism, is we've lost bowel motility. As we lose bowel motility, we get bacterial overgrowth, we get increased inflammation developing, we get increased food sensitivity and intolerances, we get damage to the lining of the GI tract, which makes us more susceptible to autoimmune issues, and that may be even the precursor to autoimmune issues, and especially autoimmune thyroid issues. But so we have slowed motility, and then the second thing is if we have hypothyroidism and we don't have appropriate acid production, now we don't get appropriate bile acid secretion or pancreatic enzyme secretion, and so we lose our antimicrobial capacity, which starts with stomach acid, we don't have bile acids, so we lose the antimicrobial capacity in the upper part of the intestine there. Pancreatic enzymes aren't secreted appropriate, so we lose that aspect of the antimicrobial capacity. And then those bile acids are really like the soap that keep the small intestine clean, and towards the towards the distal end, the further end of the small intestine, we're reliant on appropriate levels of bacteria, appropriate levels of bile acids to be absorbed. And if they're not, we don't get appropriate bile acid absorption, then we don't stimulate the host defense at the distal end of the small intestine, which makes us even more likely to have small intestinal bowel overgrowth, and it just becomes this vicious cycle. So bacterial overgrowth, we have slowed motility because maybe of a hypothyroid condition. Then we get bacterial overgrowth. The bacterial overgrowth drives the leaky gut issue, making us more susceptible to autoimmunity, more damage to attack, and it just becomes a vicious cycle.
So as we talk about bile salts in the gallbladder, I would say almost 75% of all the patients that come and see me have already had their gallbladder removed, and most of them, they didn't realize that was a crucial organ, and so a lot of them think that they're screwed at this point. So what advice do you give to patients that have already had their gallbladder removed, because that is such a crucial fact to help reduce the overgrowth later on in the digestive tract?
So for most of the people who've had their gallbladder removed, they had it removed because something was inhibiting bile acid secretion from the gallbladder or bile acid secretion from the liver. So, and then what happens is the bile gets thick, and there's multiple factors there we can talk about, but the bile gets thick, it's slowed, that creates the kind of the disease state and the inflammation, and then they wind up taking it out. Taking it out doesn't fix the fact that they still have improper bile physiology and that they got this sludge that still needs to move through the system. So almost everybody who's lost their gallbladder is going to need some form of of bile acid support, whether it's directly ox bile or it's a product that's supportive of bile formation. I use a product from Apex called Bileman. There's a product from, I think, Biotics called Beta-TCP. But some of the components in those products can be really supportive of bile function. The other thing we have to consider is that there may have been bacterial overgrowth to begin with. And so if they have bacterial overgrowth to begin with, we got to be cautious with those things, especially with the ox bile, because the bacterial overload in the small intestine can convert those what are called primary bile acids to secondary, more toxic bile acids, and that can create loose bowels and create problems. And it can deconjugate some of those things. So I look at, for most of the people who've had gallbladder problems, I think, number one, I want to look to see if they have some level of dysbiosis, because some of the bacteria that can overgrow in the small bowel can produce an enzyme called beta-glucuronidase. And if they have high levels of beta-glucuronidase being produced in the GI tract, it'll unwrap their estrogen that's trying to be detoxed and recycle that back into the system. When estrogen recycles back into the system, estrogen at higher levels inhibits the release of bile acids from the liver cells. So bile acids then can't get into the gallbladder. They back up into the bloodstream, and that can actually lower TSH levels and lower thyroid hormone production. But the estrogen can also inhibit something called the sphincter of Oddi, which is it's really where the gallbladder and the pancreatic ducts come together and empty into the duodenum. The sphincter of Oddi is what opens up to allow those acids and enzymes to enter the small bowel to help with digestion. If somebody has high estrogen levels, it will actually inhibit the release of bile acids and pancreatic enzymes. So it's kind of a complex thing, but short answer is, if they've got gallbladder problems, we need to check and see if they have hydrochloric acid problems and address that. We need to see if they have already have bacterial overload. If they do, we need to address that. If they have estrogen dominance issues, we need to support that. And estrogen is critically important in the formation of bile acid. So if they're estrogen deficient, then we need to support appropriate estrogen production and maybe support them with things like phosphatidylcholine, which can help with production.
I often find it interesting that a lot of the women who have to have their gallbladder removed are somewhere between their 20 and 35, 40 range, and most of them have been on birth control for a long time, or they are taking some sort of estrogen replacement, and so a lot of people don't link the two, and so all of a sudden then they've got estrogen issues, they then have to have their gallbladder removed, then they develop a thyroid problem, and then they have IBS and all this stuff compounds, and most patients sit there and they're like, they scratch their head and say, I don't really know how. I just, all of a sudden one day I had all these symptoms, but there was, the signs was showing them, they just kind of missed them.
Yeah, I think what happens is that, just like almost everybody else who grows up in the medical model, they go to their doctor, they have a abnormal hormone cycle, lots of cramps, lots of pain, and the doctor just says, well, we'll just put you on birth control pills, and that's it. And, most people don't have the background or knowledge to say, or to argue with a physician or to say, yeah, but why do I have an estrogen problem, or why do I have a cycle? And even those that do ask are often told that's just the way some people are, but really it probably has its roots in what's going on in the GI tract and lack of ability to detox things. And the primary way, one of the main areas of detox is healthy GI function, healthy bowel function. So, if we tie into the estrogen issue, a lot of those same people have things like endometriosis, and they have adenomyosis. And so endometriosis is, and if you have fibroids or ovarian cysts, these all things are clues that we have this estrogen imbalance or this estrogen dominance issue. But what's recently been found is that people who have endometriosis, not only does it affect the uterus and the pelvic region, but it also, you can get endometrial tissue that impedes the motility of the small intestine. So they'll call it intestinal endometriosis. And you'll see this in women who have, during their cycle, they'll have a lot more constipation and gas pain and pressure because that endometrial tissue swells. It inhibits the motility of the bowel. And you could do GI testing, and they really may not have a lot of GI issues. They may have some bacterial overgrowth that's really not a big deal most of the time. They wouldn't notice symptoms, but it's during those times of their cycle when estrogen load goes up that they're going to have more gas pain, more irritability, more Sibo-like symptoms, and it really has to do with, at the root of it, an estrogen imbalance. Absolutely.
And as we talk about constipation, the key question that is on most people's mind is what's a healthy number? I have patients coming in, they say they have a bowel movement maybe once a week or every couple of days. What do you tell your patients who come in and say, that they maybe only have a bowel movement once a week and they think that that's normal for them?
Yeah. So you think about it like trash, right? So you got to collect the trash, right? And then you've got to put the trash in the trash container, right? Which is like we eat our food, we get it into the bowel in the form that it needs to be in, but we actually then have to empty the trash, right? So if you're not pooping, then you've got all this trash that's building up and making all the smelly, noxious, toxic odors in your home, right? Well, the same is true for your bowel. The bowel, you're supposed to have 1 to 2 bowel movements per day, nice, normal size, normal shape. Consistency, right? It should come out fairly easily. It shouldn't take a long time to do that. But if people aren't going to the bathroom for days on end, then they are building up a lot of toxic waste products in their system, and those toxins then need to be dealt with. So we get we get depletions of micronutrients in an effort to try and deal with it. We get increased absorption of things called biogenic amines, which are toxins that then put a greater stress load on other enzymatic pathways. And those are the things that can make us have brain fog and depression and anxiety. So yeah, people need to go, right? And they need to go once or twice a day.
Yeah, whenever I'm healing the gut with most of my patients, and in that first week or two, they've dropped 10 pounds, and they're like, well, I've lost 10 pounds on the scales, but my clothes aren't fitting any different. So where did it come from? Most people are holding like 10 pounds of just toxic sludge or, just fecal material in their colon that they're not expelling out. And when we start cleaning out the digestive tract, healing it, your body can eliminate these toxins and eliminate them regularly. And it can be really powerful for the overall healing process.
Yeah. And sometimes people think they're doing detox, right? They read something on the line and they said, I'm doing a detox program. Well, I don't know what you're doing, but it may not be a detox program, right? But if somebody's trying to do a detox program, like clean their liver or do those things, but their bowels don't move, all you're really doing is dumping those out into the GI tract to be reabsorbed or to be converted into something more toxic.
That's usually the first question I ask when a patient says, well, I'm already detoxing. I said, well, did you heal your leaky gut and get your bowels moving properly to begin with? And they're usually like, well, no, I didn't realize I had to. And people don't realize that there's actually an approach to healing the gut, then cleaning everything out. Because if not, then one, you're going to reabsorb all those toxins. And two, if you have leaky gut, you're going to be able to get those toxins from the digestive tract into the bloodstream, which is then going to create massive inflammation.
Yeah. And it's unfortunate. There's definitely things people can do to try and increase their motility. But it does become a really complex problem to deal with. And it's not always straightforward and simple. But it is one of the things that I'm sure you do and I try and do is to try and get people's bowels moving. Because until you can get the bowels moving, it's hard to do almost anything with that person. So we have to get the bowels moving. And one of the biggest factors that relates to poor bowel motility is people just don't drink much water. That's true. Right? So dehydration is a leading cause. And you may say, well, I only drink 1 or 2 glasses a day and it doesn't seem to bug me. But if you're drinking very little water on a regular basis, then over time you do become dehydrated. It's not just a one-day thing, but it's usually a progressive thing over days, weeks, months, years. And if you're consuming things that really dehydrate you and you're not rehydrating on a regular basis, that's one of the cheapest things people can do to improve their motility.
Absolutely. As we move further, we can talk about some of the things that you recommend to help people get their bowels moving. If that's constipation is their huge main focus. I know in my office, first thing that is the hydration. I use aloe vera is a really good thing to help. Vitamin C is a really good and higher dosage will help move things along. One thing that takes a little kind of convincing to get a patient to do this one, but if they're constipated enough, they're going to do it, is coffee enemas. Is one thing that I really recommend for patients who, one, we got to get them to have a bowel movement, then we can actually do the coffee enema and help not only clean out that liver, but it's also going to help to clean out the bile salts, clean out some of that sludge from the gallbladder. Studies show that coffee enemas help to detox up to 600%. It's one of the quickest ways that you can detox the body, cleanse the colon, and it can be a really powerful thing for a lot of patients to do a coffee enema who are experiencing, motility issues, because it's also a feedback loop. By holding the enema, you're actually training your brain in reconnecting the two. And so it's almost like brain work for your gut and your brain together while doing the coffee enema.
Right. And it's not something as simple as going to the store and getting some Folgers, right?
Yeah. No, absolutely not. So there's definitely procedures. There's a lot of stuff on the internet that explain you want to get, obviously, organic, best quality coffee that you can. I think Seeking Health has a really good kind of coffee enema kit that they sell, the coffee, the bucket that goes along with it. you definitely don't want to be, having you really want a bucket, not an actual bag to do it. And so I think it even comes with an instruction manual with it. So they've got some good resources on Seeking Health's website.
Yeah, so those things, all great suggestions. I definitely get people to try and increase their water intake, whether they're going to do an enema or not is sometimes iffy. But there are some other things that lifestyle factors that they can definitely do that can help stimulate. Definitely improving their sleep quality, right? So if you don't sleep or you dysregulate your circadian rhythms, you're going to disrupt your migrating motor complex. So one of the best things to do is get people on a better sleep pattern. That can be huge to help restore motility. Definitely working on things like vagal exercises and breathing exercises can be hugely beneficial. Other things we have to consider is that serotonin is one of the main neurotransmitters that is associated with bowel motility. And when there's stress response, when there's infection, when there's autoimmunity, we have a tendency to divert tryptophan away from serotonin production and towards something called kynurenic acid, and down this kynurenic acid pathway. That means there's less tryptophan to make serotonin. There's less serotonin then to stimulate the serotonin receptors in the bowels and to move the bowels. So one of the things we can use for people is something called 5-HTP, and we can work on dosing up with 5-HTP. It's probably better to do that at night before bed and just work on small doses and build that up and to see if we can get those bowels moving, because that is a major neurotransmitter. Other things that can be helpful as far as prokinetics, you can definitely start with some bile acids and see if that can help get motility going. If they have insufficient bile acids, they may have slower motility. If you give them more bile acids, that may help stimulate it. Things like ginger can be a good prokinetic to get the bowels moving, and you may need quite a bit of ginger sometimes to get the bowels moving, somewhere up to even 2,000 milligrams of ginger. So ginger, 5-HTP, even things like mag citrate can get the bowels moving. And I usually recommend that they try and dose that stuff before bed. Start with either right after dinner or right before bed. Start with small doses, try and increase those doses until they get a more smooth movement. Definitely vitamin C. And what I'll try and do with some patients is do the vitamin C flush that I think it was Dr. Jaffe established. And if they can do a vitamin C flush and figure out where their vitamin C deficiency is, and then keep them on the amount of vitamin C they need, that can keep that motility going. For those people that none of that stuff works, definitely things like low dose naltrexone. I would have to recommend or refer them out for that, since we don't prescribe in our office. That can help with motility as well. And one of the other things that's not costly, it's not a supplement, is getting people to do either intermittent fasting, okay, or making sure they're not snacking in between meals. Because the migrating motor complex and the movement of the bowel really kind of slows down during the time that we're eating and for a period after that. And I think it starts kicking in about 90 minutes after a meal. So if you're constantly grazing and snacking during the day, then you're really inhibiting the movement of the bowel. So definitely getting them to eat really only in smaller windows, and definitely not getting them to, trying to get them not to snack in between meals.
I think that's definitely a good recommendation, because fasting definitely has its benefits. Plus, that when you start to fast, your body will actually sometimes even digest some of the undigested food or proteins that may be hanging out in the digestive tract that could be creating other symptoms. And so the intermittent fasting has multitude of benefits that go along with it.
Right, and even from a bacterial standpoint, if we have bacterial overgrowth and we reduce the frequency of putting food in the tract and slowing that migrating motor complex down, when we do the intermittent fasting, we actually kind of starve off some of that bacteria. And when we starve off some of that bacteria, now we can just improve motility just based on doing that. So if the bacteria is not overgrowing, it's not creating the gas, the pressure, the inflammation of the small bowel, then motility can start to improve just with those things.
Yeah, absolutely. Those are some great keys for people who are having some constipation or just not having the bowels moving. And then obviously you still need to fix the underlying problem. If you have underactive thyroid or we have dysbiosis, that stuff needs to be, addressed as the underlying mechanism in the first place. But that's a good starting point to get the bowels moving, because again, if it's not moving, you're not going to be able to fix the other things. And
absolutely. So yeah, if we think about it, and we kind of think of, okay, what could the layperson do? We've talked about this multiple times. Reduce their overall stressors, right? Because stress puts us in sympathetic dominance. Sympathetic dominance decreases parasympathetic activity, and to have good motility, we want to have parasympathetic activity and good vagal response. Have somebody evaluate their definitely, if they have constipation, they don't know if they have thyroid issues, they need to get that evaluated. If they're a person who's taking they've taken lots of antibiotics over their lifetime, there's really high probability that they have some level of dysbiosis in their GI tract, and they need to consider the fact that dysbiosis may be creating part of the problem. And probiotics could be helpful, but depending on where the bacterial overgrowth is, they may or may not do well with probiotics. For some people, probiotics are a wonder thing. For others, they actually make them feel worse. So
absolutely,
they can be a nifty thing. Definitely, once we address acid support's key. They can do some HCl dosing under the guidance of a doc to see if HCl helps get with that motility, because that's at the high end of the digestive tract. And I think almost anybody who's had reflux symptoms should be evaluated for hypothyroidism and a full panel like we've talked about, because that stiffness in their throat, or the feeling like they can't swallow things, or decreased esophageal movement, that may be really one of the earliest signs of hypothyroidism. And their thyroid gland may be normal. They may have a totally normal TSH, but if they have low T3 in their tissues, then they're going to have slowed motility, even if their lab values are good. So they still should get looked at if they've got those types of symptoms. The other things they want to do is definitely make sure they're drinking plenty of water. They definitely want to, under the guidance of a doc, consider whether bile acid support is needed and what type of bile acid support is needed, and potentially pancreatic enzymes. And pancreatic enzymes, we didn't talk about those much, but your pancreas produces a ton of enzymes that help you break down fats. They help you break down proteins. There is just tons of enzymes are released from your pancreas. So if there's any type of low acid production or improper digestion coming in from the stomach, you may not get appropriate pancreatic enzyme secretion. And that can allow for that bacterial overgrowth, and again, more stasis in the bowel.
Yeah, definitely. And so as we, wrap this up and talking about with, the whole digestive thing, we could have a whole nother podcast on just the aspects of how gut function affects thyroid, but we've already talked about how thyroid affects gut function, but there's a whole nother aspect of when your gut's not working right, then you're not converting your thyroid hormone properly. And so there's a whole, the gut is a foundation to pretty much any disease in the body begins in the digestive tract. And so that's where 80% of your immune system is. Most diseases are inflammatory in, nature. And so that is a starting point that, listen to your body. If you're not going to the bathroom properly, if you're having gas or bloatingness, those are things that you want to take note of. And, if you've tried to support it on your own and you are just not getting anywhere, then that's the point where you need to go and have some, additional tests, whether it's a GI map test to look for overgrowth, or whether you get a full thyroid panel, or looking at hormones and how it affects the gut. That's where working with a specialist like a functional medicine doctor is going to be key.
Yeah. And yeah, we could spend hours on the pod, and maybe we'll do another one of these. But yeah, origins of problems usually stem from gut issues, especially thyroid issues, because of the direct connection of organisms getting out of the gut into the lymph tissue and directly into the thyroid gland and triggering immune and autoimmunity. So big tie into those things. You did touch on, we do rely on appropriate loads of commensal bacteria, good bacteria, to convert some of our T4 to T3. And so if somebody's been taking regular rounds of antibiotics and wiping out their good flora, then they don't have that same level of flora to help with that conversion. And while it's thought to be about 20% of the conversion takes place in the GI tract, if you already have low conversion and you lose the GI conversion, that can be a really significant impact. That can have a pretty significant impact on your overall function and physiology.
Absolutely.
So I think we've given ourselves enough things to talk about for the next couple of podcasts.
Absolutely.
I think one of the other keys that we didn't talk about, and we should really quickly, is people with hypothyroidism. The primary cause we've talked about many times is Hashimoto's. And if you have one autoimmune disorder, there's a higher likelihood that you could have a second or third autoimmune disorder. And one of those things that is often associated with Hashimoto's is antibodies against parietal cells, which is how you produce stomach acid, and antibodies against intrinsic factor, which can affect B12, right? So if you have Hashimoto's and you have reflux or GI issues, you should probably have a panel done for parietal cell, intrinsic factor, and gastrin. And those things can give us some input to see if, okay, why I can't make stomach acid or why I'm having these reflux symptoms is partly because of a thyroid problem and partly because I've developed an autoimmune attack there as well. And that can be a huge issue, right?
Yeah, absolutely.
Yeah. And man, there's so many things I could talk about, but we're probably getting to the end of this podcast. And maybe what we do is we just we build on this next time. And we'll talk a bit more about the connection between the gut and the thyroid, because I think there's so much to talk about. But that's probably pretty good for today's episode. We've hit it pretty good. We got our half hour, 45 minutes in probably. And so we can probably wrap this one up, and maybe we just plan on doing a follow-up next week. We talk about a little bit more in depth, different parts of it, touch on some things that we missed maybe this time, maybe go in a little bit more in depth if we want, and then definitely talk about how gut-based things and what type of organisms can affect the thyroid gland, and then how people can go about getting tested to find out if at the origin of their issues is some level of dysbiosis, whether it's bacteria, whether it's yeast, parasites, and then if they have dysbiosis, which is small intestine or large intestine in nature, how they can identify, maybe by looking at labs, if they have acid problems or bile problems. So we could probably touch on all those things in the next couple of podcasts.
Yeah, absolutely.
Okay. So we'll wrap up today. This was episode 12.
Yes.
We did a great job, even though it's just you and I and no additional guests, right? And if people need to get a hold of you, Erica, why don't you let them again know where you're located?
You can find me at brainandbodyhealthcenter.com. That's Brain and Body Health Center on Facebook, and then it's Doctors Riggleman on Instagram and Twitter. Yep.
And I am at chronicconditionrecoverycenter.com. You can also find me at thyroidproblemsdoctor.com. And those are the big places to find me. My videos are all over Vimeo and YouTube and on my website. And I will be speaking next week and emceeing the upcoming ShyCon conference. That's the Seeking Health Educational Institute, where people can, doctors and specialists in health and nutrition will be coming. Functional medicine docs will be coming to Seattle to learn more cool stuff from Ben Lynch and our team at Seeking Health. And for those of you who can't attend or don't have tickets, there will be some live streams. So you can go to seekinghealth.com and you can watch the live stream of the conference. And I think we got it, right?
Yeah. I mean, that's going to be a great event. There's doctors from all over the world that come to this to learn, because it is so in depth, and the knowledge that's going to be there is going to be amazing.
Yeah. Oh, that's what I didn't talk about. Didn't talk about methylation and all. Dang, I forgot about that. All right. So we'll wrap up today. I think that was great. We covered a ton of stuff, and we're just going to have to come back and go over this a little bit more. So have a great day. Enjoy the beautiful sun out there. I hope the sun is shining in Winchester.
It is.
Yeah. I got to go watch some lacrosse.
Yeah.
All right.
All right. Have a good day.
All right. Take care.
Bye.